In this week's video I will talk about posterior ankle impingement and how it looks like on MRI. So this video will mainly focus on the posterior ankle impingement, but I might be doing one or two comments about posterolateral and posteromedial impingement. But if you want to know more about it, go check the links in the description down below, and you might find some links to literature and references that are dealing with this topic in more detail. Now, as in with the other impingement videos, just a quick heads up. MRI's role is also to exclude other stuff and not necessarily to make the diagnosis of ankle impingement, and that's true for posterior ankle impingement too, because typically this is already suspected clinically with typical pain in end-stage plantar flexion of the foot, and it's not so much a diagnosis that we should or can make on MR alone if you don't have any clinical information. So, but nevertheless, it's a good topic to go through some anatomy here, and we will now focus on a few key structures that you should look at when having an MR with this question or with this clinical information. Now, this is the posterior aspect of the talus, and we have the posterior process of the talus, which is comprising two different tubercles. So this is the fibula, so this is the lateral side. And this very prominent tip or process, some call this the posterior process, is actually the lateral tubercle of the posterior process, and then there is a medial tubercle as well. In between we have this groove, and there runs the tendon, the flexor hallucis longus tendon, in this groove between these two tubercles here. I can also show you this here in this 3D image here. So this is now a posterior view, and you can clearly see these two tubercles, so the lateral tubercle and the medial tubercle, with this groove here where the tendon, the FHL tendon, runs down below. So what's actually happening with posterior ankle impingement? Now you have your ankle, then you plantar flex your foot, and there is some mechanical conflict here in the posterior region of the ankle joint. Now, if there is no abnormal structure, then you might not actually be prone to this. But if you have, for example, a large osteogonum or a osteogonum no matter the size, then you might be inclined to have a structure here that is impinging between these structures while you flex your foot. However, with osteogonum, size does not necessarily matter, because there is not a really good correlation between size and symptoms. The other thing you can have is just a very prominent lateral tubercle, or a prominent posterior process of the talus, which is sometimes called a stieda process. So if this one is really large, it also takes up some space, and therefore you can have a mechanical conflict there. The other thing is, if you just have a osteoarthritis of the subtalar joint and you have some osteophytes here, they can also be responsible for this kind of symptoms, or if you just have some kind of loose bodies or ossicles from osteoarthritis or whatever reason. Now, these were the bony problems that can cause posterior ankle impingement, but there is also like a soft tissue structure that can actually cause posterior ankle impingement, or is actually written about in the literature. And one of the ligaments that can be impinged between these different structures is the transverse tibiofibular ligament, so this deep portion here of the posterior tibiofibular ligament here, part of the posterior syndesmosis. So this ligament, we can have a look later on the MR. And the second structure is the intermalleolar ligament, which runs from the fibula to the tibia here, and there are some varieties where it actually inserts. Sometimes it's in the middle, sometimes it goes further medially. So these two ligaments basically, this is just to show you that there is some anatomic variable. So if you want to know more about these kind of ligaments, I have a separate video about it, and you can check the link up in your upper right corner if you want to know more about it, or in the description down below. So this is just an overview of the different structures that can get impinged. Just quickly here, osteogonum, prominent joint recess with some kind of synovitis or synovial proliferations here. Then obviously the tendon itself, FHL, its tendon sheath, and I actually forgot what this structure was supposed to be. Now, in the literature, there are sometimes really funny images, like in this study here. You will find the link to this paper in the description down below, and you can see they show nicely here these different ligaments. So this is the inferior transverse ligament here with this solid arrow here, which is then looking quite normal here. And then this one is the intermalleolar ligament, which looks normal on this slide, and then a little bit more medially, it seems to be a little bit thicker and changed in signal intensity, and they postulate in this paper that this is actually causing the impingement, or might actually be the result of impingement. But it's just because it's a female ballet dancer with clinical already suspected posterior ankle impingement. Otherwise you would never make this call. At least I wouldn't. So let's go quickly through the anatomy, and we can see here on this theorem sequence sagittal view that there is a ostrigonum with extensive bone marrow edema, and also on the other side of the synchondrosis there is some bone marrow edema too. So this is one potential reason for ankle impingement. And if you look here on the transverse section now closely, you can see the medial. So this is the medial tubercle, and this is the lateral tubercle, which is then not fused, forming here this ostrigonum. And in between, in this groove, is the flexor hallucis longus tendon. And you can now also understand why you can get problems with the FHL tendon. So if you have the tendon sheath here, it might get impinged or maybe scarred with this kind of structures here, because it's really running here through the posterior aspect of the ankle joint. And of course you can have osteophytes here, and if this one would be fused and that prominent, you could call it a stellar process. Now let's have a look at the other structures that I mentioned in the theory part. So this is the fibula, and if we scroll medially now, so you can see here parts of the PTFL, and if we scroll medially, you can now see here this lip, this kind of black structure or ligament here, which is the deep portion of the PITFL, so the posterior inferior fibular ligament, which is a part of the syndesmosis. So this basically is this deep portion that you can also see here. Just quickly to make the repetition here in blue. So this is this ligament here, which is completely normal in this case. So you have this black lip here just adjacent to the posterior portion of the tibia. And if you look closely now, you have another ligament here, which is the intermalleolar ligament. And if you scroll medially again, or laterally again rather, you can see here the ligament. It's coming from here to basically together with the PTFL. It's running across the joint, just where we have the joint capsule here. So this is joint capsule. And then it's blending in somewhere here with this kind of structures. Now, it can sometimes go up a little bit earlier, and the one example that I showed you there had some changes here. So in this patient, both these ligaments look absolutely normal. There is no joint effusion. There is a little bit just a normal joint recess down here with this kind of changes, and the FHL. There is no tenosynovitis. Now, don't fall into the trap to call this now a posterior ankle impingement syndrome if there is no clinical information that is indicating that, because this patient was completely asymptomatic with this regard, and the problem was actually something at the greater toe. Just a quick Patreon update. I would like to say thanks to Lucas, who is the newest patron who joined this week. Thanks, and also thanks to all the other patrons for their continuing support. Their monthly pledges or donations really keep me going. And if you want to know more about Patreon and what you get as exclusive content, go check the link in the description down below or somewhere here. And if you have any questions regarding this, just write me an email or contact me via LinkedIn. So here we have another patient, and unfortunately I don't have an actually confirmed case of posterior ankle impingement in the collection that I have access to. So I have to really focus a little bit more on the anatomy and make maybe some assumptions. Now this is a patient with an ankle distortion like a few months ago with persisting pain, but there is no indication in any of the reports where the pain actually was. He's got other problems too, as you can see here, this sleeve avulsion here, and then this very extensive scarring of the deep layer of the delta ligament. So something like this is sometimes in literature also given as a potential reason for posteromedial ankle impingement. Because if you look here on the transverse sections, you have this kind of scar tissue here that can actually get impinged. So just to keep that in mind. But again, I think the literature is not really good. So I think one of the main issues is this fascial sleeve avulsion here. But it's interesting because this patient also has a ostrigonum, and you can now see on this very 3D sequence here also again the anatomy. Now let me zoom in a little bit. So you can see here we have the fibula, and then we have from the fibula the PTFL, which is running over here, and part of it is inserting onto the trigonum here, and the other portion here, which is the intermalleolar ligament, is then going up here, and then we have this very dark lip here from the PITFL, the deep layer, which is going all the way over here, but basically they look quite unremarkable, to be honest. So I wouldn't really call anything here to raise the suspicion of posterior ankle impingement, but I just show you this case for the lack of a better one. And you can see we've got other problems. So we have this osteochondral lesion with this subchondral cyst, cartilage damage here in the posterior aspect of the ankle joint, which certainly will also be symptomatic. Just a little side note here, you can see there FHL with quite a lot of fluid here. Just keep in mind that in 20% of the cases you can have fluid in the tendon sheath of the FHL, and it's still considered to be normal because in 20% of cases there is communication with the joint space. So this alone doesn't really make a tenosynovitis of the FHL. You can raise the suspicion of tenosynovitis of the FHL if it's really extensive, going all the way down, and there's some criteria and literature which we will not cover today. So I think I'm really sorry that I don't have an actual case, but I think just look at the different structures that we went through, like these two ligaments, osteogonum or stator process, some osteophytes, and make sure there is nothing else explaining this kind of symptoms. And if you have the clinical information of posterior ankle impingement, you can really go crazy and start finding tiny pixels that look abnormal in these two ligaments, or maybe even in the trigonum, and really try to, I don't know, put yourself in a very good light. But it's just because you have the clinical information, and if you don't have the information, maybe don't try to really be very smart. So that's why the role of MRI is maybe not super important. At least that's my opinion, and if you read other articles, they see it differently. But hey, it's a free world, isn't it? Oh, and before I go, if you actually have a case, feel free to contact me, send it to me, and I might do a exclusive video for my patrons, so I can show them an actual case. I don't want to pick just a random case from Radiopedia or anything at this point. So as you can see, ankle impingement syndromes, they are not that hard because you really just have to know the anatomy, and if the suspicion is high, you can really go into detail and you can start shining if you really want to pick out these different structures. If it's not known, I would be more cautious to really give the indication that it could actually be impingement, because it's in the end a functional diagnosis from clinical testing and history, etc., and not really easy to see or to depict on a static MR image. Now with that, thanks for watching and see you next time.